Hi, and welcome back to AbPsych. Now we're looking at treatment part 3. Just as we've been seeing with theoretical perspectives, there are many possible explanations. So too is there the same case with treatment approaches. We'll start, anywhere from psychological to biological. We will consider some of the leading and contemporary approaches in treating depressive and bipolar disorders. The psychodynamic approaches. Psychodynamic treatment of depression has traditionally focused on helping the depressed person uncover and work through ambivalent feelings toward and the loss of objects, thereby lessening the anger towards the inward. Modern psychodynamic approaches tend to be more direct and briefer and focus on developing more adaptive means of achieving self-worth and resolving interpersonal conflicts. The focus is on the here and now rather than the unconscious and the childhood experiences in the past. Behavioral approaches, learning theory approaches have focused on helping people with depression increase the frequency of reinforcement in their lives through such means as increasing the rate of pleasant activities in which they participate in and assisting them in developing more effective social skills to increase their ability to obtain social reinforcements from others. Essentially, learning theorists considers the depressed behavior is learned and therefore could be unlearned. Cognitive approaches. The cognitive therapist focuses on helping depressed people identify and correct distorted or dysfunctional thoughts and learn more adaptive behaviors. Focuses on learning one's own dysfunctional thinking and to develop more adaptive behaviors. This will often use thought diaries to help clients to increase their self-awareness and to better manage their adaptive choices. So by doing a diary, you can write down things on a day-to-day basis with a focus on how are your moods, and over time can start to get a handle on what are the antecedents to these moods, what leads to, what are the moods looking like, and then what are the consequences, and then how can I use either the antecedents or the consequences to compensate and augment and improve my mood responses. The biological approaches, they have focus on the use of antidepressant drugs, which you would expect. That's always what the biological will do, and other biological treatments, such as electroconvulsive therapy. Yeah, it sounds like what it is. It's not fun, but it's also not used as frequently as perhaps you might imagine. Antidepressant drugs appear to increase the levels of the neurotransmitters in the brain. The TCA, or tricyclic antidepressants, MAO, the monoamine oxidase inhibitors, and then we did mention the SSRI, or the selective serotonin reuptake inhibitors. Bipolar disorder is commonly treated with lithium, effective in stabilizing moods and reducing depression and mania episodes. Despite significant controversy, the electroconvulsive therapy, the ECT, is a treatment of choice for very severe depression. The person is anesthetized and is given a muscle relaxing drug. They are then given a brief, less than a second, shock directly to the brain. The result is a brief seizure lasting several minutes. Treatment is usually administered about once every other day for 6 to 10 treatments. The side effects can include some short-term memory loss and confusion, which usually disappear within 2 weeks. What is interesting is that it's been fairly successful. About 50 to 70% of people who did not respond to medication do respond to ECT. Now, a difficult topic, and it's always a difficult topic, is of suicide. Suicidal thoughts are unfortunately common enough. Fortunately, most don't act on these thoughts. So who does commit suicide? Well, mood disorders are often linked to suicide, although women are more likely to attempt suicide, but men are more likely to succeed. And that's probably because men select more lethal means. The elderly, not the young, are more likely to commit suicide, and the rate of suicide among the elderly appears to be increasing. About 28% of people between 85 and 89 commit suicide. 25% for 15 to 24-year-olds and 16% for 25 to 44-year-olds. Now, something we don't often consider or think about, but it does occur, is suicide among children and adolescents. The rate of suicide climbs with age, rising from about 1.9 in every 100,000 for children ages 10 to 14 to 7.7 per 100,000 for children and adolescents between the ages of 15 and 19. Among youth aged 15 years and over, the rates are greater for males than females. The rates are 5 to 7 times greater for young people in the First Nations and Indigenous youth. So why do people commit suicide? Well, people attempt suicide are often depressed, but they are generally in touch with reality. They may, however, lack effective problem-solving skills and see no other way to deal with their life stressors other than suicide. The theoretical perspectives on suicide, well, classic psychodynamic representation, they see the representation of inward directed anger and turn that anger towards themselves rather than what they want or what they need. Sociologist Emile Durkheim, he identified the concept called anomie, A-N-O-M-I-E. And it's a term that describes feelings of being alienated or a disconnection that you feel with others. Durkheim identified this concept and said that they are more likely to commit suicide when you experience anomie. And this fits the sociocultural view today. The distance that we travel for school, work, bigger cities, less connectedness over time. The more we sit in bigger cities, the less we seem to be connected to people, even though there's people all around. Learning theorists point to the reinforcing effects of prior suicide threats and attempts, and to the effects of stress, especially when combined with an inability to solve personal problems. Social cognitive theorists suggest that suicide may be motivated by positive expectancies and by approving attitudes towards legitimacy of suicide. Biological factors that appear to be involved in suicide are serotonin deficits, and same as what's linked to depression. Perhaps genetics and family history of suicidal behavior. Predicting suicide, I don't think it's possible to predict. Evidence points to the role of hopelessness as an important predictor or perhaps a contributor to suicidal thinking and behavior. Researchers have found that people who commit suicide dispose of their possessions suddenly and try to sort out their affairs, and may purchase a gun despite the lack of prior interest in firearms. Okay, I hope this has been a helpful video, and we will be moving into Chapter 5, Dissociative Disorders and Somatic Symptom and Related Disorders, and that we're going to do in 2 videos. One will be dissociative disorders, the other will be somatic symptoms disorders. All right, I hope this is working out all well for you. I hope you're getting enough good information. Keep your e-text handy. You can make notes in it. I don't think I've mentioned, but I will mention now, you will find at the end of each chapter little quizzes, and you can do them to help. You'll get a score. Those scores won't count in the overall grade. They won't be counted in Blackboard. The only things that will be counting in Blackboard will be work that is assigned through your syllabus. All right? but use those test quizzes and examples as a way of practicing and getting familiar with content. All right, everyone, bye for now, and we'll see you next week. Take care.